Be defined. I'm ready. Thank you for coming.
Good afternoon, everybody. Welcome to the University Interdisciplinary Colloquium. I am Michael O'Rourke. I'm the interim director of the MSU Center for Interdisciplinary. And the University Interdisciplinary Colloquium is a series of talks. This is for those of you who are new. It's a series of talks that the Center for Interdisciplinarity sponsors that are designed to celebrate innovative interdisciplinary research that features the arts and humanities. Arts and humanities are often left out of the conversation when people talk about interdisciplinary work. And what we're trying to do with the center, and especially through this series of talks, is kind of establish for the community just how central the humanities and the arts can be to interdisciplinary efforts. This series meets twice monthly in this room. And the next one will be in 2 weeks on the 12th of October, when Professor Benjamin Loren from Writing, Rhetoric, and American Cultures will be here to deliver a presentation entitled How Project Managers Foster Interdisciplinary Communication. Today, we're very excited to have Professor Don Opel with us. Professor Opel is Assistant Professor of Digital Media and User Experience in the Department of Writing, Rhetoric, and American Culture at MSU. She has a BA in History from Wake Forest, a JD from the University of North Carolina School of Law, and a PhD in Rhetoric, Composition, and Linguistics from Arizona State University. Before joining the faculty at Michigan State University, Professor Opel served as a postdoctoral fellow of computational humanities and data science at the Institute for Humanities Research at ASU. Professor Opel is a community-engaged action researcher who partners with legal, healthcare, and nonprofit organizations to improve the coordination of care across sectors. And today she's with us to deliver a presentation entitled Caring About Health Services, Humanities-Driven Healthcare Reform. Professor Opel.
Thank you. Thank you all for being here today, and especially to the Center for Interdisciplinarity for inviting me to talk with you and for hosting this series. My name is Dawn Opel, and I'm Assistant Professor in the Department of Writing, Rhetoric, and American Cultures in the College of Arts and Letters. The talk that I'm giving today is called Caring About Health Services, Humanities-Driven Healthcare Reform. And in the next 30 minutes or so, I hope to share with you some of my thoughts and experiences from the perspective of a scholar of the humanities who is also a health services researcher and an advocate for healthcare reform in this country. So I'll frame the talk in terms of several questions. First, what is health services research? And what roles might humanists play on health services research teams? How does work on these teams change what we consider to be the work of the humanities? And finally, what is the impact of this interdisciplinary work, both on health services research and on healthcare more broadly? For the last two questions, I'll use examples from my own work in mid-Michigan, working with community partners to improve care coordination strategies across clinical and community contexts. So to start, for those of you who may not be familiar with the field of health services and with health services research, I'll begin with some definitional work. So the definitions of health services research may differ in terms of what disciplines are included, what methodologies and concepts are employed, and where the sites of research might be. What is consistent across these definitions is the focus on the system of healthcare delivery, and this is versus more visible and better funded experimental research that is focused on R&D of medical procedures or products. Health services research, by comparison, receives federal funding of approximately $1.5 billion a year when compared with total federal health research funding of about $34.3 billion. This was in 2003, but I say that to emphasize that the largest piece of the puzzle of health services or of federal health research funding is related to clinical trials, and this is quite different work. So health services research focuses on access to care, costs of care, and quality of care, with particular emphasis on those patient populations who experience health disparities or higher burdens of illness, injury, disability, and mortality as compared to other patient populations. A focus on health disparities in health services research requires going beyond disease outcomes and instead focusing on health and well-being of patients inside and outside of the clinic, with a focus on prevention and health promotion services. So here, this is a diagram that the CDC created, and the base of the pyramid in this diagram is aimed at what are called the social determinants of health. And that is the economic and social factors such as distribution of income, wealth, influence, and power that affect health disparities. And so they indicate that the largest impact of work that can be done is related to the social determinants of health. Most of the funding that I was just mentioning occurs in that second tier of the pyramid, clinical interventions. So in many ways, health services research is something of a shapeshifter, depending on the composition of the research team, its funding, its stakeholders, and its purpose. The University of Washington Department of Health Services lists some of the challenges to defining health services as a field of study, and I've listed them here. And a lot of this is the ambiguity in the definition of what health research is, but that's in part, and I would say even more than just part, because of its markedly multidisciplinary nature. I would also suggest that an area of study that is focused on systems change, invested in addressing the root causes of social problems, is one that will have to rely upon multiple disciplines, disciplinary approaches, and orientations, which is what contributes to the disparate nature of study designs, theories, concepts, and timeframes in health services research like they list here. So this is also what makes this work hard to fund and even harder to do, because the work shifts as it's site-specific and contains often intractable issues that are embedded in networks of cause and effect. So health services researchers like me work on site, implementing best practices and trying to change cultural and social, behavioral aspects of the delivery of healthcare. So some examples of research areas within health services are as broad as health economics, policy, technology assessment, and health promotion. Health services research teams might include economists, public health professionals, technologists, health policy experts, clinicians, and researchers from across the social and health sciences. That's primarily where often health services research is housed as a field of study in either social or health sciences somewhere. Could be in public health, it could be somewhere in a medical school or in another discipline in health sciences like epidemiology. Yet about 3 years ago, when I was a postdoctoral researcher in the digital humanities at Arizona State University, I was working alongside health services researchers, and I started to ask myself, how is a field of study that is so focused on equity and justice, so focused on the ethics of spiraling healthcare costs and the creation of health technologies and systems that only seem to complicate and obfuscate our current American healthcare crisis, not a place for humanities scholars? So this is one of the many things that I've been told over the last 3 years that that sort of led me to have this felt difficulty with why humanities scholars and researchers are not involved in health services research. So at this point you might be asking yourself, how might a researcher from the humanities find themselves on an interdisciplinary health services research team? Well, the argument that I'm here to offer is that humanities expertise is critical to the mission of health services research, and that there are ways for humanities researchers to join in this work and on these teams. One of the ways that my colleague and collaborator, Professor Bilhard Davidson, and I, who we work on several projects here at Michigan State, have theorized and practiced this work is through the implementation of what is called the health literate care model. So a little bit of background on that. In 2013, the Assistant Secretary for Health and Human Services, Howard Koh, and a research team proposed a new healthcare delivery model for providers in the United States called the health literate care model, meant to transform care by emphasizing preventative care, shared decision-making, and enhanced care coordination, particularly for those patients most affected by health disparities due to social, economic, and environmental factors. These are team-based approaches to care. So you see where they're talking about teams of literate healthcare teams, patients and partners, community partners, systems change, activated patient and family teams, all working together. And so the idea is an integrated practice of health and medicine across a team of clinicians and other sources of support for the patient. Enacting the health literate care model requires humanities expertise such as rhetorical aptitude, attunement to ethics, access and equity, writing and literacies, and critical engagement with emerging technologies. While a team-based approach to care is laudable and a step forward from clinic-focused biomedical models, which you may be familiar with in terms of just thinking about patient care in terms of doctor-patient and one-to-one, that encounter is your doctor and you. Thinking about team-based approaches to care is a laudable move forward. But the model's adoption of the term health literate poses ambiguity. The model refers to health literate systems, organizations, health literate teams, health literate patients, and health literate activated families. So what does that mean for all of these entities to be health literate? How does that change their practices and their knowledge? Well, the health literate care model's co-authors describe it this way. Quote, as noted in the Affordable Care Act, engaging patients in their own health care fundamentally relies on health literacy. That is, their ability to obtain, process, communicate, and understand basic health information and services. Unfortunately, relatively few people are proficient in understanding and acting on available health information to fully engage in their own care. We then propose a new health literate care model based on health literacy universal precautions. That is, the need for healthcare providers to approach all patients with the assumption that they are at risk of not understanding information relevant to maintaining and improving their health. So this description that Coe and his team give of health literacy is at once technically narrow, like a set of skills that you can obtain and possess and then have better health and wellness. And it's also expansively broad, that it requires skills across reading, writing, speaking, listening, cognition, decision-making, and many other things. In my own field of rhetoric and writing studies, Ann Wysocki and Johnson Iola describe this seemingly contradictory phenomenon of describing literacy. They write, too much is hidden by literacy, we think, too much packed into those letters, too much that we are wrong to bring with us implicitly or no. They elaborate in arguing that when we speak of technological literacy then, or of computer literacy, or of fill-in-the-blank literacy, and I would suggest health literacy, we probably mean that we wish to give others some basic, neutral, context-less set of skills whose acquisition will bring the bearer economic and social goods and privileges. Yet, Coe et al. Are invoking a system that implicates many more stakeholders beyond the patient. In fact, the health literate care model, in this model, as much or more of the burden lies on enhancing provider skills to communicate. The word literacy obfuscates the social determinants of health and the social justice-oriented activist work that is inherent to improved health and wellness for groups historically disadvantaged by systems such as the medical industrial complex. As Wysocki and Johnson Iola write, the word literacy keeps us hoping, in the face of lives and arguments to the contrary, that there could be an easy cure for economic and social and political pain, that only a lack of literacy keeps people poor or oppressed. Humanities expertise at the intersection of writing, rhetoric, and literacies then offers much to the work of the transformation of the healthcare system. As Bill and I have suggested in our scholarship, the arrows in the literate care model's diagram haven't yet fully been realized. What does it mean to have a productive interaction? What intervention or what work does it take to move toward this model? We don't know how yet to create productive interactions across teams and across systems as diverse as clinic and community-based organizations. Our projects then test different interventions to improve shared decision-making and care coordination. So before I offer some more detail from one of these projects, I want to present this press release, if you can see most of it there, which appeared in the Health Services Research Journal. It discusses a hot-button issue in health services, patient rates of readmission to the hospital. In order to address hospitals with very high rates of readmission of patients, or this is also patients who were discharged and returned back to the hospital within 30 days. The Center for Medicare and Medicaid Services implemented a hospital readmission reduction program, which penalized higher than expected readmission rates for Medicare patients for the hospital. The hospital essentially gets hit with a lower rating and also may be subject to other penalties if they have too many Medicare patients who are being readmitted to the hospital. A study was conducted that indicated that, surprise, the community in which a hospital resides affects these statistics. So what's interesting to me is the very last line here, which says, a healthcare provider responded that these community factors, including income and employment levels, are, quote, reasons beyond the hospital's control, end quote. I offer this because this mentality is exactly what I work very hard every day to combat. The notion that what exists outside of the clinical setting is somehow not a part of healthcare or the responsibility of the health and medical industrial complex. So addressing the health disparities requires a change to the business of healthcare. This is a cultural shift that requires caring about the ethics of healthcare in ways humanists are uniquely poised to engage in. So I say here, these are the kinds of statistics that health services researchers look at. American adults receive recommended care only about 55% of the time. Disparities exist in the way care is delivered to racial and ethnic minorities, and 30% of healthcare spending is wasteful and produces no value to the patient. So, to illustrate, I want to tell the story of a participatory action research project that I've been working on for about 2.5 years, improving care coordination in mid-Michigan. Almost as soon as I arrived at Michigan State as an assistant professor, I began working at 2 community sites, Sparrow Hospital in Lansing, Michigan, and Elder Law of Michigan, which is the statewide nonprofit law firm for older adults. At Sparrow, I was a faculty fellow at the Center for Innovation and Research, which is a shared research unit between Sparrow and MSU. And I was charged with creating a research team with Sparrow clinicians and pursuing grant funding on issues related to the core mission and vision of the center, which are closely related to the goals of health services research. I arrived at Sparrow having completed a postdoc where I worked to create online resources for healthcare providers for their use in practice transformation under the Affordable Care Act. So I was creating a lot of documents that healthcare providers would use to try to do some of this work that now I am involved in, and Bill and I together are involved in doing. But this was my first opportunity to actually become involved in the practice transformation myself, not creating materials for those to do it, and I was looking for the right team and project to begin. So serendipitously, I was brought on to a project at Elder Law about the same time as I began at Sparrow. And at Elder Law, I was an attorney and did poverty law work when I was an attorney. And they were looking to transform their call center workflow. So that was why I was initially brought in. And while I was there, I learned of a cloud-based tool, a technology tool that Elder Law had developed and was testing to coordinate client services for older adults across legal and social services organizations. As I met more and more Sparrow professionals, I realized that at Sparrow, the same kinds of conversations about how do we build an online database of community service organizations, how do we start to involve community partners in our population health initiative and start thinking about the social determinants of health, they were beginning to percolate. Like, it was right at this moment where, within 1 to 2 to 3 years, there was going to be some action, and so I kind of seized on that opportunity to start to collect and collaborate with like-minded partners and units at Sparrow. And so collaborating with partners from the Senior Health Clinic at Sparrow, the Sparrow Care Network, and then the Tri-County Office on Aging, which is the social services agency for older adults in mid-Michigan, we wrote a seed grant for the center to begin a project to try to work across all of these spaces and network care coordination across legal, social services, and health and medical contexts. So what I'm going to do here is sort of show you how I would talk about this project if I was talking to health services stakeholders, and also talk to you in the ways that I'm talking to humanities scholars about the same work. So I'm going to do a little bit of translation work, and that's something that I think that I do every single day as I work across all of these disparate professional and academic contexts. So the next slides offer the exigency for the specific project, the model for the intervention, and the specific aims of the study, so what we're doing in this study. These are what I've presented to numerous stakeholders on the project, including community-based organizations. So I've gone around and done some outreach to talk about it with nonprofits in mid-Michigan to try to build some community and get folks interested in doing the work of care coordination. Also to policymakers and the public, because this work is closely related to the Affordable Care Act and to incentives that are offered under the Affordable Care Act to enhance care coordination practices. So at the same time, I'm talking to and offering some humanistic inquiry and frameworks back to my own field of rhetoric and writing studies. And so I'm going to read to you from an excerpt from a forthcoming article in the journal Literacy and Composition Studies to show how this work informs my work as a rhetoric and writing scholar and as a humanist. So, a humanistic approach to aging and interdependence in the healthcare setting. I'm working with older adult patients, obviously because of the work with the Tri-County Office on Aging and Elder Law of Michigan. And this humanistic approach to aging and interdependence requires a cultural shift that requires dialogue across differing epistemological positions. Community literacy studies offers a framework to intervene in the discourse of health literacy that I talked about earlier, and to present an explicit move away from the biomedical model of health, of both literacy and aging as individual skills and abilities, or a deficit of skills and abilities at the individual level, and toward a collective, distributed set of mediated actions to give and receive care. The health literate care model recommends health literate community partnerships across clinical and community contexts. This is often called community care coordination, or working in a team with medical and non-medical professionals and caregivers to coordinate care. This recommendation is a previous step above which was previously recommended under old models, which was to encourage individual patients to take these steps alone. So the current cultural paradigm in the biomedical model is to get the health literacy skills of individual patients sort of bolstered up to a point where they can take care of themselves alone. And so it avoids all of these challenges that I usually start with the exigency for the project, which is it's very difficult to coordinate clinical and community practices because the practices are so different. So happily, we're now moving to a place where if you go to your primary care physician, you will likely be screened for certain social determinants of health, like food insecurity or housing insecurity. But then what? You know, this is sort of the place I think that primary care is at, that they don't know then what happens if someone says that they're food insecure or housing insecure. Like, what is the role of the clinic to move forward after that? Also, often there are wonderful people in the clinical setting that have great informal networks of community partners that they rely upon, and social workers are an excellent example of this, that they know who to reach out to if someone needs, say, Meals on Wheels or another program that's in the community. But however, the reliance on informal networks and a lack of uniform knowledge across clinics means that you get very inconsistent referral patterns and care patterns. You also have these wonderful outdated phone directory books, and they do still use print phone directories to call community partners from inside clinics. I've seen this happen in nurse triage. It's quite something that in this network digital age that's still what's going on. But it is, and they're always outdated because if you've ever worked for a nonprofit, the rate of attrition is fairly high and turnover of staff and people moving from place to place, so they're almost outdated as soon as they're printed. Then, you know, if you've ever tried to connect to someone on the phone tag is a drain on the efficiency of community care coordination in the clinical setting. Everyone is worried about HIPAA and the sharing of information, and so that inhibits our ability to share across clinic and in communities. And then last, you know, the crisis that we see, particularly in primary care, is a time starvation buried in paper billing and documentation, which is what Bill and I write about, and a focus on payment, which is fee for service, so based on how many folks come in the door each day and go out each day with a diagnosis and treatment for an illness. So the project then that I'm working on with Elder Law and with Sparrow is to create a space for networked caregiving that is focused on working together in delivery. So it's hard to think about how this, what these steps are going to look like when often in the past, or even still today, this is often invisible labor that you would perform yourself as a patient or by caregivers that are family members or hired caregivers that would work for older adult patients. So that frequently means that that invisible labor is often the work of handling your own referrals yourself. So if you think about a brochure that might be handed to you at the end of an appointment, that would be handed to you, and then you would go home, you would make the call, try to sync up with whichever service it may have been recommended to you, and then wait to make an appointment or play the phone tag, do that yourself, right? So a more networked and collaborative approach to care is a significant cultural shift for clinical practice. And for this reason, the Affordable Care Act contains incentives to attempt this kind of relationship building and practice transformation. This is a new and controversial activity as it takes time separate and apart from the fee-for-service care that healthcare clinics and hospitals typically provide. So for example, if a provider spends an hour on the phone with Meals on Wheels to ensure that a patient is eligible for services, that is not an hour that can be billed in the same way that a patient can be billed for an acute illness and treatment. Further, information technologies such as the electronic medical record do not facilitate data sharing outside of a siloed healthcare system. That is why the Affordable Care Act is trying to take part of the policy is to incentivize this work, because under the current system, the healthcare provider loses time and money to try to work with caregivers rather than delegate work to them, so that gets delegated. So this model on the bottom is what we're trying to achieve with the digital tool that we're using on this pilot, which is to create a networked system of care around the patient rather than put all of the onus on the individual patient to do the care coordination for themselves. So the incentives that the ACA are offering create an opportunity for networked, caregiving-focused community literacy. Healthcare providers, patients and caregivers, and human services professionals have very different vantage points when it comes to healthcare delivery, but all would agree that healthcare delivery is a site of struggle in the US today. From waiting room to nursing station to ivory tower, all agree that coordinating care inside and outside of the clinic is close to impossible. What all stakeholders are looking for is a space to communicate with one another across institution and community where effective coordination can take place. That is, where can providers, caregivers, and community-based professionals work together? So the project then is a cultural one to create this space. And as you can see from the slides, these are the specific aims from the grant. We are piloting a technology tool, but the work is actually to measure and test acceptability of working together across sectors. And a focus on the technology tool is often sort of blinding this larger issue and larger discussions of how and why we perform work in clinics and community organizations the way that we do. So how are professionals compensated or evaluated? What is the workflow of a patient encounter in the clinic? How do community organizations truly know that they have helped to make a client's life healthier? So how can they measure health outcomes? These are the questions of healthcare reform, of moving from a fee-for-service model to a value-based system. Values in more ways than one permeate that transformation. So I posted the specific aims because this reads in a very scientific, study way. However, the values that I'm saying are imbued and permeate this work aren't often spelled out in the grant application. However, they are critical to the outcome of the work. And so I think that's really important for humanities researchers to understand, that often it seems as though their expertise is not visible in a grant application, and yet if you read behind the language and sort of the discourse of scientific grant applications, what you see is that the values and the ethics that promote this work are critical to their outcome. And that has been something that has been very hard for me to understand and to learn how to translate to other humanities scholars, but it's critical that they learn, because otherwise we won't have a seat at the table to participate in large externally grant-funded projects. And so I'm trying to kind of balance between the language and the persona, the identity and the discourses of the scientific community and those of the humanities community at the same time, which is very difficult work, but it's also very impactful work. So I've detailed one of my own projects here, but I'm just as hopeful that this talk can serve to build capacity for other interdisciplinary health services projects. And I'm going to conclude by discussing a grant-funded project that I'm working on with a Michigan State and Ohio State University team to support humanities-focused healthcare services research and activism. So the Building Healthcare Collectives project is a Humanities Without Walls initiative-funded project designed to center humanities expertise in healthcare. We are seeking BHC project fellows who are interested in participating in or leading action-oriented health equity research. The Fellows Program is open to all interested in participating across the disciplines at any rank, including graduate students, at any rank in the university, and also clinical and community partners. So we're looking to cast as wide a net as possible. Those that are interested in healthcare reform, in health services research, in health equity, we encourage you to apply from any discipline. And our project goal is to create an infrastructure where healthcare professionals, interdisciplinary academic researchers, community partners, and activists can work together to solve key problems facing the US healthcare system. We provide research and training for team formation, study design, and grant procurement, and we match like-minded researchers across institutions and organizations. So we're doing some matchmaking with academic researchers, community partners, both here in Michigan and in Ohio and also elsewhere. So what we're really looking to do is find people who would like to try to break into this kind of work and train them and provide them an infrastructure to get a team up and running. And if you have a project that you might want to pursue scaling, that you might be working on by yourself, or have an idea that you'd like to incubate, this is a great place. And so what we're going to do is kick off with a symposium that's held here at Michigan State and at Sparrow Hospital in Lansing next April 11th through 13th, 2019. So I really encourage you to promote this to your students, to others who might be interested in it, to members of your community who are interested in healthcare reform. Please send everyone our way, because I think that is the way that we can have the most generative conversations, but also really render visible in important ways the work that the humanities can do in healthcare reform and activism. So if you're interested in joining us or know someone who might be, please jot down this link, or you can come talk to me, and you can find some more information on this website, and also a very short application where you express your interests and your background. So with that, I'm going to leave it there. Thank you so much for listening, and I'm happy to answer any questions and continue the conversation. Thank you so much.
If possible, we'd like to have you use the microphone if you have a question to ask. Questions?
Is it on? Hello? Yes?
Yep. Yeah, we're getting.
Oh,
It's for the video.
Hello, Alexandra.
Hi, Noah.
Hello.
So now you're doing this pitch, which is awesome. To help the pitch, I'm going to ask a question. How do you represent this to your department as something that counts as research, right? How you take this incredible work you're doing and explain it for your merit review, toward tenure. How can people do that?
Sure. So I think all of us who are community engaged researchers face this challenge of the sort of historical understanding of the ways in which scholars and researchers are evaluated for promotion and tenure, and the narratives that we need to build and promote to help other community engaged researchers succeed. And so a large part of that is, I think, particularly we as early career scholars, and you are one as well, have to make an argument for public intellectual work that is more robust and multifaceted than simply traditional scholarly publication. And I think that our department does a phenomenal job of helping us, supporting us in making those arguments about the goal of academic research is ultimately to make the world a better place, and that is what we are here at this institution to do. And so, so what it requires is, I think, a sort of spelling out of the different dimensions in which our work is visible and heard and taken up. And so part of that is when I give a community talk, including and making visible the slides, the discussion, who was there, what stakeholders are involved in our conversations, and understanding that that dialogue is as meaningful and important to the world as a traditional scholarly publication. That being said, I would say that we're in a moment where, as community engaged scholars, it's a both and proposition to a large degree. We're still also having to teach our own fields how to, this counts. And so therefore, writing that article about this work, that's why in this talk today, I'm sort of balancing writing these articles with Bill and this new piece that I have, and thinking about the ways in which I'm constantly translating the work to different stakeholders all the time. And so it's very time consuming, but it's so rewarding to know that the public knows what I'm doing, that I can walk downtown and I see people that I know because we're working on this together, and that that I feel like it creates a dimension to being an engaged scholar that is really rewarding to me, and I don't think I would do it any other way. And I know you wouldn't either.
If for somebody who might be more interested in mental health care delivery, does health services research happen there? Does it sort of see biomedical healthcare delivery as the same thing, or is it distinct?
So the difference would be, and this is kind of hard, I think, to explain to people, is that, and I can give you an example like this, that a new treatment, say for depression, would not be considered health services research, but the way in which you would access that treatment through your primary care physician, through like sort of how do you get to that treatment, that is health services research. So, so it requires thinking about the sort of the ecology in which biomedical good products and services circulate. So, so it's very easy to test in a clinical, well, I would not say that, it is not. And any clinician here would be like, no, it's not. But it is in some ways a more elegant proposition to do a clinical trial of a depression drug, because you can isolate it, you can do this, like, you can put it in a vacuum, you can get some participants, see if it works, yay, and then you get FDA approval. To figure out if people are actually getting to that treatment, if doctors are prescribing it, if your health insurance will pay for it, if all of these things, you can't do a study to figure out how to make all that happen. So that's what's hard about health services, and that is absolutely within the purview of this work. So it's more about the uptake, so I frequently am told by medical professionals that they're like, well, we have best practices for that. There's evidence for that. It's done. We conducted those studies. It's, that drug is out there. But if no one can actually get their hands on it, then we still have a problem, don't we? Like, so that's what I frequently say, that if you go to the hospital and no one is taking that medication, even if the clinical trial was like a resounding success, it doesn't matter. I mean, people are still sick over here. So that's the work of health services.
And just as a follow-up to that, if you were talking about like a non-medical intervention for depression, like a talk therapy, would that change the
the piece at all? Would it still be considered part of health services research?
Yeah, I think again it depends on where you're looking at how you're addressing the problem space. So patient-provider communication is a huge part, and shared decision-making is a huge part of this work. So a talk aloud protocol or something like that would be absolutely like this idea of how do we engage patients and how does communication affect health outcomes is definitely a part of that. So yeah, absolutely, yeah.
Great, thank you.
But again, this makes it so much gray area. That's why that slide with why is this so challenging to figure out how to do? This one here, but why is it so hard? Well, you've got people from 12 disciplines working in it. They do 12 different methodologies, or 12 million, and the studies are all different. So so it makes it very difficult to say, does this count or does this not count? But in general, if your purpose is to improve access to and delivery of costs of healthcare, you're working in health services.
Hey, I was wondering if you could talk a little bit more about how you think about understanding and health literacy models, because we know that sometimes that can be pathologized, like when we talk about lack of insight, and that's actually used to cover disagreement or alternative ways of experiencing health.
Yes.
And you touched a little bit on it
Yes.
in your talk, but I was wondering if you could expand a bit more.
Sure, absolutely. So, so one of the things that Bill's here now too, so he can talk with me about this because this is what we work on. So I talked in the prepared remarks about how the word literacy is sort of a catch-all. That that often what I have noticed is that in the medical field, often the word literacy is sort of a stand-in for anything that is social, cultural, or behavioral. It's they need improved literacy. And it's also from a position of that right now, all of these stakeholders are somehow, working at a deficit, right? And you're right, that can mean, it can mean a variety of things. And it can be because it's a stand-in for reading, writing, cognition, decision-making, it has the concern that it also may be, a loaded term to talk about what other things people may lack. And those lacking things can be economic, they can be related to mental health, they can be related to cultural or racial difference. So that is why we somewhat problematize the notion of health literacy will solve for all of the problems in the healthcare system. Now that's not to say that that this model isn't designed to get folks communicating and coordinating better. But the question is, why are they not now? And the argument that I make in the paper that I was reading from is that really it takes the burden off of healthcare, the business of healthcare administration, and puts it all on patients, families, and individual providers. So the notion that it's broken because of all of these stakeholders who are not healthcare administrators, who are not, healthcare insurers or payers. And so that it shifts the conversation to a certain degree. But yeah, so I think your discussion is or your question is a really good one, because the getting down to brass tacks about this blame and shame of individual patients for why they are not healthy really shifts the discussion away from some of the discussion in the slides about the healthcare system and its failings.
Yep.
No, it's on.
It's on.
Just for
Sorry.
the video.
I would like to just raise a question based on research that I and my colleague, Dr. Luz, have been working on for a number of years, and that is the production of art, visual arts, by patients, people who have a variety of conditions, but also the receipt of that art by others who also might have health challenges. We've been documenting both the makers and the receivers for a long time, and the stories that are embedded in both the production and the receipt are filled with clues to both the health and well-being of the maker and the receiver. And so one of the things that, well, actually, it's her study, part of it, based at Sparrow Hospital, is how can you train medical professionals to be able to understand that there are clues embedded in these humanities forms, both the art and the stories, the narratives, that if you don't pay attention to those, you are not going to be a good provider.
Absolutely. So I think you're getting at what a productive interaction might look like if we incorporated other kinds of ways of knowing. And I think that's a really important connection to make, that the medical arts and humanities have a lot to offer in terms of what this communication strategy looks like. And it enriches a notion. We're frequently told that doctor-patient communication, or in general, what these literate practices might look like are, soft skill development, or, you can take a 3-hour class and learn how, empathy, or, and what you're suggesting is that the arts and humanities might have some real strategies to employ that would enrich not just like how to communicate, but also the content of those communications. And I think that is a really good example of another way, beyond the ones that I talked about from my study and from the ones Bill and I work on, that humanists can offer interventions that flesh out this model in important ways. So I definitely see that connection, that what it means to meaningfully communicate or have a productive interaction or learn from others. This also heavily, I think, privileges certain kinds of knowing that are really, that are very clinical. And so I think your work would probably bring that out in certain ways.
Yeah, and one of the things we were doing is we were testing it with actual objects and then the digital objects as well. And so testing with doctors, fledgling new medical students, what does seeing this and hearing this story mean in terms of changing yourself as a future caregiver?
Yeah, that's great.
So, working in bioethics, I'm familiar with some of what you're dealing with here, and one of the things that I'd like to press on a little bit is, the epistemic stuff is an obvious concern, right? I mean, there are issues of, how do experts talk to non-experts, and how do you get people to internalize knowledge so that they see situations differently? But even prior to that, there's some interesting stuff on the trust factor, right? So before you can really have an interaction that's meaningful, both parties have to buy in, and that's not very easy to do in some circumstances. There are, communities that have been, basically pushed out of, medicine in general, but, healthcare at large. And I wonder, does that trust factor play into this research and how to establish that relationship?
Absolutely. So I would say that where I'm seeing that the most in this study that I talked about is that this specific aim is written to measure and test acceptability of software, but it's not really about acceptability of software in the sense that everyone in the database has to want to work together, and they have to believe and trust the other. So a lot of the community-based organizations I work with are deeply distrustful of healthcare. And healthcare thinks that a lot of these community organizations will flake out. So they have this belief that only certain ones are reputable. So those are the ones that they'll deal with. And so there is deep distrust on both sides. So using the tool, it's not really whether or not the tool is acceptable. It's, they'll only go in and, try to connect if they really believe they could work together. And so that takes relationship building. This is why I'm on year 3 of this project, and we are barely we are moving at a glacial pace, because really I have to make everyone believe that everyone is trustworthy, and one of the biggest concerns they have is that how do you vet who's involved. And they really are concerned, and for very different reasons, which I find fascinating. But then, yes, you add what patient populations don't even come in the door at all. And yeah, that's a whole nother like can of worms that I'm hopeful to work with. And some of the community partners that I work with or have approached me, that's something that they talk about. Like the director of the Cristo del Rey Community Center said to me, we have a clinic here on site, and so the idea that if we could leverage what we do here, people are more trusting because this is their community. They know who's here, and they're not going to go over to Sparrow for help. But like if we can do something here, then we can coordinate care here, then it will work. And I'm now very attuned to the notion that you cannot. There is no tech tool that's going to solve for community coordination. It is all relationship building. And you're right. Like trying to mend broken relationships from historically criminal behavior on the part of the medical industrial complex is pretty hard to fix. But I think that knowing that a human, someone who works in bioethics knows that. I have plenty of folks who are like, just buy the tool. Epic has an add-on. Just get it. We'll do it. But you are aware of that, so you can say, just because you've got a tool doesn't mean people are going to do it.
Yeah. I'll give you an example of that, Chet. In the patient provider, I'm on a project in which what we're working with is a text messaging system that allows trust building and communication between patients and providers managing chronic illness. And we had to have a really tense conversation when our old vendor left, and we had to think about what the new arrangement would be for sending texts, about why an EMR system that was connected to federally qualified health centers would not be used by the Hispanic population. And I said, do you know what they're using those phone numbers for these days? I want you to think very carefully about what it would take for somebody to give up that personal information about where they are, who they live with, just to get a blood pressure update from you. So it isn't only the case that there's a lack of trust, there's abuse on the other side. And
there's a reason for the lack of
absolutely, they're the rational actor in this situation, right?
Thank you. First of all, I commend you for the work that you're doing. It is hard, it's messy. I'm a gerontologist, health services researcher, all community-based participatory research, and it's messy and it's hard. And it is hard, she left, but to convince your administration of this when you're going up for promotion or tenure. It is hard to get funding, especially when the university is putting such pressure on people to get NIH. So but it's worth it. I wouldn't be doing anything else. And trust is huge. And I have 2 projects I would love for people to know more about. One of them is called Impart Alliance, where we're trying to work with home care workers, personal care workers, who are marginalized, haven't been heard, have total distrust for the medical system, but also big time for academics. So we have spent years building trust relationships, and that's imperative. I've had people leave our board because they said, you are too process-oriented. We want action and we want it now. So we can't handle all of this relationship building. So we've actually adopted, wear this tortoise all the time, and everybody on our board has a tortoise. I keep reminding people, slow and steady, slow and steady, slow and steady. In the end, the tortoise wins. This is about building trust, right? It's also, I think, about building a better definition of health. We never question, what do we mean when we say good health and well-being? And we talk about outcomes, right? Patient outcomes. And one of the ways in which I'm getting traction is by tying everything back to improved patient outcomes. But our definition of good patient outcomes is so limited, it actually doesn't include the arts and humanities, which is why I was here today. one of the things, the other organization I'm trying to develop right now it's a new program on campus called Age Alive, and we're taking, one of the things we're committed to is interdisciplinary research, team-based research, but also inclusive of the arts and humanities. And let's talk about health in terms of more than just physical outcomes or mental health outcomes, but what is quality of life and well-being, and how do we measure whether somebody's, they might be physically healthy, they might be have no mental illness, but they're not happy, they don't think they have good quality of life. So how can we change that? And I think there's a role for the humanities in that as well.
I absolutely agree with you. Yeah, I had, for this piece on health literacy, I was doing a lot of reading of humanistic gerontology and thinking, and many studies that say exactly what you're indicating, that measuring health and happiness, well-being is not an easy, it's not a easily quantifiable thing.
And I think that's what Marcia was alluding to as well, is how do we just break out of this idea of good health as being so clinical and biomedical, and listen to the stories and the objects and the art that people use to express themselves, and how can we use that to teach people about the human experience of health and well-being. So that's one of our goals, is to try to broaden that definition of what we mean by good health.
And we work with other collaborators. Yeah, we love collaboration. So maybe there's a place that we could tie into what you guys are doing.
Yeah.
So I think we have time for one more question.
More of a comment that might be useful for you guys. So Michigan State University is part of the Alliance for the Arts and Research Universities. It's a consortium of about 44 universities, and they specifically have an arts and health initiative that they've been working on for about 3 years now. They have a conference every year, this year at the University of Georgia, and they usually put a pre-conference together on arts and health, both working on arts and medicine and how that's different from arts and health and arts and well-being, and how do you kind of attempt to identify those components, but also how do you find collaborators in pushing this forward?
I'd love to break it. I didn't know that, but we don't know about that.
Yeah, A2RU. So
There was a National Association of Arts and Health, too.
correct.
It's coming back.
Okay, very cool.
I was wrong. We have time for one comment and one question. One more. So anybody else? Well, if not, then I'm going to ask a question. I'm curious about your thoughts concerning the implications of this kind of work for graduate training. So what do we do as a College of Artists and Humanists to create programming that enables our graduate students to leave Michigan State capable of doing this kind of research?
That's a really good question. So I would say, and it's also the sort of focal point of the Humanities Without Walls initiative. So the capacity building component of that not only includes who we're inviting to participate as fellows, but the graduate student RAs who work with us on that initiative. So they have the ability to learn from us on our own projects, as well as gain their own experience in cross-disciplinary, collaborative work. So I think being on teams as graduate students is fairly critical to being able to running one yourself when you get done with graduate school, or to even know how to enter another team. So I'm in a position as an early career faculty member where I am looking for partners that are more senior on these grants, so that those senior PIs can get really, we can scale, because I can't get an NIH grant my first year out of graduate school, although I did try. But anyway, so I think that you have to be able to model the experience of being on teams, and the arts and humanities, sometimes it's hard to find those opportunities to do that. So I think that what positioned me the best myself as an early career scholar was to work in a digital humanities lab, because I was working with teams of people on grant-funded projects every single day. So that became the business model that I was familiar with in the academy. And then what was interesting is when you put me back in a discipline, I was like, wait a minute, I'm supposed to go sit in this office and but I think that really signals to me that how transformative that kind of a So interdisciplinary centers like DH Labs create those environments, but research centers and research projects like Humanities Without Walls also create them. Right now in the curriculum, I don't have an answer for that.
So just to follow up on that, the Center for Interdisciplinarity is going to be launching a team-based transdisciplinary graduate fellowship program in January that will have as one of its where teams work with community partners, and one will be Mid-Michigan Clare Health Center. So yes, just to mention that for graduate students in the room who might be interested.
Yeah, we're accepting applications starting Monday.
What's that?
We are accepting applications for that program starting Monday.
Yes. Okay.
We just got one of the internal I3 grants to create a program that matches students and graduate students with elders to together learn about aging, and so that they get the intergenerational experience. So, we're trying to create some models that could be replicated that would bring the two
fantastic.
together.
I'm going to follow up with you both about that.
Okay.
That's a great opportunity. Yeah, thank you.
Thank you, everyone. Remember, 2 weeks. Professor Warren will be up.